Okay, welcome back. We're going to now talk about the early phases of acute stroke, acute ischemic stroke plan of care, and what's happening pathophysiologically with these patients. Again, my name is Michael Nanney, and I'm with MedEd Seminars, and we're going to continue this wonderful educational slides. So, code stroke, think of it as a brain heart attack, and why do we say that? It's just simply because it's also a time-sensitive issue. There's something that's happening in that first hour that we need to intervene. Just like as in a heart attack, you have a decreased amount of blood supply to the myocardium. Here we've got an occluded vessel, especially with ischemic stroke, that is decreasing our blood supply to our brain, and that becomes a big problem. And why do we care so much about it? Because it is the third leading cause of death in the United States. It is the most frequent cause to cause adult disabilities. It is one of the leading causes of getting patients placed into long-term care facilities. And look at that, more than 800,000 strokes occur each year in the United States. Wouldn't it be nice if we could just get rid of that? And individuals who've had a previous stroke or have had TIAs are 10 times more likely to repeat that experience. So with that being stated, and more than 800,000 strokes per year, you can see the need as nurses to be educated, and not just emergency room physician nurses or emergency room physicians and emergency room nurses need to be educated, but all nursing staff, because a stroke does not really have any, it doesn't say, oh, I'm just going to take care of, or I'm going to let all blue-haired old ladies have strokes. No, it's not prejudice. Any age, just about, any financial, socioeconomic status, any race, any religion. It just is not one to say it picks and chooses. So we all need to understand that. Stroke risk factors, hypertension, we know is the biggest one. Hyperlipidemia, because I got too much fat in my body. My triglyceride levels are elevated. My HDLs are low, and my LDLs are high. Atrial fib, new onset of atrial fib. I think we understand this very much, just simply because new onset of atrial fib causes the atrium to sort of have this chaotic depolarization up in the atrium. Blood starts to pool, blood clots get in there, and then what happens is that they start to get over in the atrial appendage. And then we decide to stop the atrial fib because we were able to cardiovert, and what happens, that little clot floats out, and then it starts floating out to the body, and instead of going to the heart or to a gut or into the lungs, that little clot decided to go up into one of the vessels of the brain, and it occluded, again, my garden hose, so now I have lost all my pressure and blood in that area going to that part of the brain. And just like the myocardium, we do not get regeneration of brain cells. Diabetes, again, diabetes is one that, again, it affects the blood vessels' ability to dilate. It affects that nitric oxide. Smoking definitely can do that because of the vasoconstrictions and stuff that occurs. There is actually a slide or a video that actually shows, just for example, how smoking affects blood vessels. They have a patient laying on a cardiac cath table. They're doing cardiac caths and looking at blood, and they're having the patient smoke non-filtered Camel cigarettes right after each other, and they actually see the coronary arteries and the vessels spasm. So it's quite interesting to see how that works. And of course, cardiac diseases, atrial fib, atrial flutter, old MIs or new MIs, things like that. Because with cardiac disease and with atrial fibrillation, the first treatment or the first thing that we're going to think about is preventing the cardiothrombo stroke or cardioembolic stroke. Then, like an atrial fib, then look at controlling the rate, and then the third thing, controlling the rhythm. Now, the other thing, too, is what about cerebral metabolism? We know that the glucose is the brain's only source of energy for cellular function, and it does not store it. So it is constantly got to have a good blood supply. So the brain's up there screaming for glucose all the time, and oxygen, because we need really good aerobic metabolism going on up there to meet our energy needs. So in other words, I need some good oxygen, and I need a lot of glucose. And we also got to keep the cerebral blood flow as at a constant and normal pressure as well. And if that blood flow gets interrupted, then of course that's going to affect our cerebral metabolism. So without the adequate perfusion, then that area, the environment, or really the brain area, becomes acidotic and from the lactic acid production. In other words, I go from aerobic to anaerobic respiration. And that leads me to have cellular damage. And if we're greater than 5 minutes, we get a good destruction of blood cells. And as I've got there, cannot be regenerated, because we all have learned that. Now, in addition to is that the autoregulation is vital to the brain. It also has a way to help with oxygenation and ventilation and stuff like that. It also helps with maintaining blood pressure and all that. So, but if we start affecting that because we don't feed it, then those functions can be messed up. So as mean arterial pressure increases, the cerebral vessels constrict. And if they decrease, then they dilate a little bit. If your PaO2 is less than 50, then those vessels up there are going to be dilated because they want more blood, because they need the oxygen that's getting up there. And then so therefore, if we don't get the oxygen up there, then lactic acid occurs, and there again, then we've got the environment that promotes anaerobic respiration. Now, what about the functions of the brain and stuff like that? Things that it sometimes, unless you're a neurointensive care nurse or you're a certified stroke nurse, certified neuro nurse, you understand all this very well. But one thing that I think of too, like, when I think of the heart, I think of the left ventricle as being mama. I need to protect her. She's the big one that's involved. Well, you have mama up here in the brain too, and I call it the frontal lobe, or you can see it as the frontal lobe, because it has a lot to do with your personality and stuff. So take, for example, you get a patient in, she's a patient in her 80s, and she's married to this Baptist minister, and they've been married for like 50 years. She's been so prim and proper. Her etiquette is all perfect. She's a very loving. Everybody loves this lady. And she shows up, and you go in to see her, and this lady is cussing up a storm and is more aggressive. You're going to think, what is going on with your frontal lobe? Things like temporal lobe and so forth like that will deal with your hearing and so forth, and behavior and speech. And you just sort of know these things. Occipital lobe, we all know it's vision, because everybody says, oh Lord, I'm starting to have headaches when I'm trying to read, so we go get our eyes examined. And then parietal lobe, we're looking at language and sensation, stuff like that. The cerebellum is like balance. So this is why a lot of things change in our assessment, stuff like that. So you just remember it as frontal, parietal, occipital, and temporal. And this just lets you know of what's going on. Now, what is actually happening pathophysiology with the stroke? Well, the stroke occurs within the blood supply to the brain, is decreased due to the bleeding or either the occlusion. So either I've had a hemorrhagic stroke or I've had an ischemic stroke. And then after about 4 minutes of that poor blood supply, that anaerobic respiration begins, so lactic acid increases. That causes a decrease in adenosine triphosphate, your ATP, which is a lot of energy that you must have if you go back and remember at the beginning of nursing school at anatomy and physiology class. Then what happens too is now that sodium and calcium start to enter the cells. Well, what follows sodium? Fluids, water. Okay, and when that does that gets in cell, we get cerebral edema. Then the cerebral edema leads to the exacerbation of decreased blood flow because my brain is enlarged. This is a closed area. That skull is enclosed, and when you got brain and blood and cerebral spinal fluid, if one increases, the other two must decrease. And that has been proven by the Monroe-Kelly doctrine, or used to be known as the Monroe-Kelly hypothesis. They hypothesized that if one increases, the other two have to decrease. Well, they got proven. So now you have this Monroe-Kelly law, and that is basically what's going on, with the brain being about 80% occupancy of the skull in there in the cranial area, cerebral spinal fluid, and the blood being about 10%. So if my brain swells, then I'm going to decrease my blood supply, which is going to exacerbate my problem and just make things worse. And if that blood supply really decreases and I get a lot of pressure, well, where is it going to go? Well, guess what? Down into the foramen ovale, because you got that base of the skull, and what sits down there? Your brainstem, your pons, and your medulla. And just think, guess who controls blood pressure, respiration, and heart rate? Right down into that area. So now you can understand why patients go into Cushing's Triad. When that blood pressure raises up, heart rate drops, respirations drop. Your patient is doing opposite of having shock, is what they're doing. And this telling you now that herniation has occurred. So you can see why now we need to really back up the slides and say, okay, this is what's happening, what do I do? Because I don't want slides, 4, 5, and 6 to occur. So brain herniation occurs, like I said, blood pressure goes up, heart rate and respiratory rate goes down, so it's opposite of shock. It's known as Cushing's Triad. So there's another triad for you to learn and understand and have in the back of your brain. The respiratory patterns, as you can see, once you get down to the medulla, you have periods of apnea and respiratory arrest. So ponting, you start getting apneustic breathing. You get a little bit fast, you might get a little bit slow, you'll have periods of apnea. But then you start to get, basically you're herniating, and once you get down to this point, because you're affecting 3 major important things that go on with the body, again, the brain needs autoregulation, and now we have got it out of that autoregulation, and so we do not have a true good area of functioning that is going on neurologically. So how do we rapidly assess? And so we start using rapid stroke assessment. Now, BFAST has pretty much replaced the FAST assessment, which was the Cincinnati pre-hospital screening that you learned in ACLS. And the books have not changed. I just wonder what's going to happen in 2020 and 2021. But BFAST comes out of Presbyterian out of New York. And you can see why now it moved to BFAST, because we talked about the brain, and we talked about balance, and we talked about eyes, and we talked about face, arms, and speech, and where all those occur, and that frontal lobe, and so forth. So you remember FAST was face, arm, speech, and time. They switched up a little bit. B is for the balance. My patient, I'm feeling dizzy. I feel like I can't walk straight. I'm having some vertigo. And eyes, they lose vision in one of the eyes or both of the eyes. So that tells you, when you start looking at that, am I having pons area type stroke? Am I having occipital area stroke? As far as motor and so forth. You've always heard people are left brain or right brained. That means left brain people are very analytical, very mathematical, can analyze stuff. If they have problems like what is 2 plus 2 and they can't come up with the answer, it could be left side that's going on. Creativity, like when you look at the picture, when you're doing the National Institute of Health stroke screening, they look at the picture and they're supposed to tell you the ladies washing dishes and the kids on here and stuff like that. They start getting into something else. They can't seem to, their creativity portion does not work. They end up telling you something that may not even be related to the picture. That time and terrible headache still is, again, it's a vital thing. We like to know when the patient's last normal, because we think we only have about 4.5 hours to start really instituting therapy to make the patient do better, especially if it's ischemic stroke. Now, the other thing that's also looked at is that we look at VAN. Do we have visual disturbance? So the patient do they have problems seeing? Is it blurred vision? Have I lost the sight in one eye or both eyes? The other one is aphasia or dysphagia. The patient also is having problems with speech. Don't forget also, this also leads you to checking about dysphonia. Does the patient have swallowing issues? And this would be a big indication too, again, or a supporting aspect to implement the nursing care of making your patient immediately NPO. The other one is the neglect, because what that means is that they can't raise the arms and stuff on one side, or everything is, or they're ignoring one side. That means they're not letting that side move. So I found some articles and got this out of there as far as what does VAN stand for, and it's the vision aphasia and the neglect. And what is stroke VAN? It basically is dealing with large artery strokes is what they're looking at, and tend to be more worse and disable patients more. So you're assessing if the patient's having a stroke, but we want to know, is it the large vessel? Because that's going to really make your problem be more critical. And so the other thing that then you must do is establish your Glasgow Coma scale also with your NIH score. And start doing that, because you've got to remember, again, you've got a patient in critical crisis here that is now starting to have problems. Do you have A, B, C, and D? Evaluation must occur in order to prove if you have A, B, and C, and because you already know that D is going to be not in the normal response. So look at best eye opening, best verbal, and best motor response. The beautiful thing about it is we really don't have to remember it. It's usually in our EMR under the Glasgow Coma Scale, and we could just answer all the questions, and it even calculates it out for us. So that even helps us out. So what are the stroke signs and symptoms? We already talked about be fast with balance, eyes, face, arms, speech, and time. So look at this, the sudden onset of facial weakness, sudden unilateral weakness. They can have the confusion, difficulty with speech, so they have a problem with dysphonia. That could also be I'm having problems with swallowing, they're getting choked easier. So a big reason why if you think you're having a stroke, we're going to make you NPO. Visual disturbances, I'm dizzy, everything looks blurry, or I can't hardly see out of it. It's like somebody's covered up half my right eye, or they've covered up my right eye, I can't see out of it. Numbness or tingling of the face, arms, and legs, and also maybe some near syncope episode, because you know what, we're not getting the oxygen and the glucose up there, so it's not uncommon if patients start feeling like they want to pass out. So with that in mind and an unsteady gait and all that, think about safety of your patients. Now, what can lead to altered mental status? It may not be a stroke. Is your patient just intoxicated? Have they got alcohol poisoning? Do they have uremia that is going on? Think about the infections of our older populations. They like to be very confused when they seem to get a urinary tract infection. Trauma, did they hit their head? Do they have a closed head injury? Anything like that. Increased ammonia levels, okay, because the body treats ammonia as a waste product that is eliminated by the liver, so if the liver failure is done, then the ammonia stays in there, that waste product is in there, and it will cause you to have some nice good confusion and altered mental status. What if you had a seizure and nobody saw it? So, and now you're sort of like unresponsive, floppy, and you voided it, the patient's voided all over themselves, they've got drooling going on. We wouldn't know that unless it was observed or unless we asked or we inquired, oh yes, this patient has a lot of seizures. This is what was going on with this patient. As far as toxins, drugs, sedatives, anything like that, what about a patient that may overdose on their Ativan? Anything like that, or even your street drugs, your heroin and your cocaine, or anything, even large doses of marijuana can basically affect patients like that. So what about immediate assessment? The first thing you ask, is this a stroke? Do I think my patient's having a stroke? And then if so, okay, when did you start acting like this? Or when is the family member? Have a family member there and try to find out, try to pin it down. If they just said, hey, sometime this morning, try to get, well, was it right after breakfast? When do you eat? Yeah, it happened right after breakfast. What time do you eat breakfast? I eat breakfast at 8:30 every morning, and just right after that. So somewhere around 8:30 this morning is when it happened. You want to know that, and you want to share that information and make sure everybody knows that. I see emergency room nurses actually take a marker and they just write on the head of the bed the time and circle it, so anybody that comes in the room knows that 8:30 was the last normal. Do I have airway, breathing? What is my blood pressure? How am I doing circulation? So forth. What deficits do you see? Is the patient unable to raise the right arm? Does the patient have to turn the head all the way around and look at it because, to the right because they've lost their vision in the right eye? Just what's going on. And you start thinking what needs to be done, and you already know things that need to be done. Again, that ABC is the priority. It's a time-sensitive issue. What's happening within that first hour? We should get that patient to CT immediately. Don't forget about if you need to put the patient on oxygen, do so. Make sure you are watching those blood pressures. If that patient is hypertensive, it is not going to be anything wrong with you pulling out the manual cuff and confirming that and checking it in both arms. Definitely get a 12 lead. We need to know if the patient has had a recent MI or is experiencing an MI, but the neuro seems to be overriding everything here and masking some of those signs and symptoms. The other thing too is that we also want to know if the patient's got new set of atrial fib, because that may have been the culprit of all of this. All these things up there should occur within the 10 minutes. Sometimes it's just getting the patient to CT, and while you're over there, putting them on to O2, put on a lead apron and get their blood pressure, draw lab work, and so forth. Again, what is your initial impression of the patient? Do I have a patient that is alert, trying to follow commands, or do I have somebody that's totally unresponsive? Was the symptoms acute? Or did they come over slowly? That may be an indication versus ischemic and hemorrhagic stroke. What is their current level of consciousness? Glasgow Coma Scale, use RAS score, use AFPU. All those are acceptable. Put all three of them in there. Really paint a really good picture of this patient experiencing this neuro emergency. How responsive are they? Pupils, remember that if it's on the right side is where the injury is, then we're going to have problems with the right-sided pupil. Everything else will be left-sided. And that is the work of the cranial nerve number 3. Check it with orientation. It's going to be time, place, and person. They're not going to know the difference between breakfast, lunch, or dinner. Then they're not sure about where they are. And then as far as person, do your BFAST assessment. Repeat it if you have to. Do it several times. What else are we going to do? Well, like I said, the immediate CT scan. Patient has altered mental status. Do not forget to check. Make sure the patient's not hypoglycemic, because severe hypoglycemia can send you into a true altered mental state. It can actually send you into a comatose state. 12 leads, cardiac biomarkers. You want your 12 lead. Check your electrolytes. Go ahead and draw a CMAT, a complete metabolic panel, electrolyte panel, and let's make sure that nothing there is out of whack that could be affecting everything else. Don't forget about your blood count. We're looking at hemoglobin, hematocrit, and so forth. And let's check that white blood cells. We definitely want a PT, PTT, INR, because most likely we're going to be instituting sort of the blood clot buster, and we need to make sure everything's fine. One of the worst things to do is you've got a ischemic stroke, you start them on TPA or something, the next thing you know we got a hemorrhagic stroke. No nurse ever wants to experience that. Don't forget to check too about blood alcohol content. Is your patient just severely drunk? Or have they used some drugs? Again, complete set of vital signs. Make sure you have that weight in kilograms. That is so vital, especially now because drugs are going to be administered and distributed based on the weight of the patient in kilograms. Real quick slide about what happens when a patient has a right-sided CVA versus a left-sided CVA. So left brain damage on the left side, because again, that is left brain people who analyze and calculate and good at math. He comes up and tells you 2 + 2 is 5. Those right-sided people, they're going to have left-sided arm problems, left foot and everything like that. But the pupil will be affected on that right side. So this is a great slide to do this and to understand pretty much what happens based on right-sided versus left-sided ischemic strokes. Now, the most common of the two types of stroke is the ischemic stroke versus the hemorrhagic stroke. We just basically have a blood clot in there, an embolus has occurred. Basically, we block the blood flow. Like I say, we block the water that occurs in a garden hose. So we don't get good blood supply up to the brain. And when that happens, then we start getting into anaerobic respiration, lactic acid increases. Then therefore we don't get the blood, which is oxygen enriched, and the glucose up there. The sodium and the calcium start floating into the cells. Fluid starts floating in there. Brain cells swell. That increases your intracranial pressure, and then your Monroe-Kelly doctrine is starting to be affected. Now, as far as ischemic stroke, it's classy. It just basically looks like we got a blocked out vessel just like we do in a heart, but this is now into the brain. And so we need to fix this. And the beautiful thing about it is multiple things are now being done in order to get this fixed. So the nursing care is to get blood flow restored as fast as possible. Again, optimizing oxygenation and ventilation, and let's have good positive hemodynamics. Control the blood pressure. If blood pressure is severely elevated, let's bring it down so that we don't make that ischemic stroke into a hemorrhagic stroke. And when you bring down that blood pressure, you want to do it slowly. You do not want to drop a pressure from 180 to 110 all of a sudden. It can cause spasming up there, and we can exacerbate our decrease in blood flow to the brain. Give the oxygen if you need to. Make sure that they can swallow. They've got good gag reflex. So you can see why swallow screens are now implemented. So until that is been proven and been done, your patient is to remain NPO. 2 IVs, the reason why I say 2 IVs is one, because if you do have to start TPA, you must have a dedicated line. So what are you going to do if you have an emergency? What if you need to give something to help with blood pressure like that? What if you need to get some more labs? You need to use the other IV. So at least get 2 IVs. Consider a urinary catheter before you do TPA, because once you do TPA, we're not going to be sticking things in our patients because you can get a lot of bleeding. So if you think your patient needs a urinary catheter, then you go ahead and do that. At least now we have some sort of what we call non-invasive catheters through condom caths and the PureWick type system. Get history from the family if possible. Find out as much as you can. Has he done this before? When did it happen? Does he take any drugs? Does he drink? Does he smoke? Does he take medication for blood pressure? Has he seen a neurologist before? Does he have a cardiac history? Anything and everything that you can find out. You take in that information. You'll know what's important and what's not important. Don't forget about doing venous thrombosis prophylaxis. If they're going to be up in the bed, start instituting sequential compression devices. Get the head of the bed up. The head should be elevated at least 30 degrees. This promotes blood flow to the head. It helps with the venous return and getting blood flow up there. And also because of what's going on with your patient again has got to be transferred out. Now, in this case, they may be transferred to a stroke unit, to another campus, or just they're going to move from your area to an area that provides the appropriate care for your patient under this experience. And you look at there, and sometimes they may have to go to the stroke lab, like we have a cardiac cath lab, and they can do a mechanical evacuation of a clot. So now you can see why we have what we call stroke nurses that are on call, and they run that lab like they do the cardiac cath lab. They're available 24/7, 365 days a year. Okay, TPA is still one of the major drugs that's being good. Alteplase tissue plasminogen activator is what TPA stands for. It is approved by the FDA. It does not require any type of consent for administration. There are guidelines for TPA administration, and usually it comes with a list, and somebody's got to check that list off, like is the patient at least 18 years of age, is the blood pressure this, has the patient had recent surgery, is the patient on blood thinners, has the patient had a previous stroke. All this stuff, and based on the answers of that, we would determine if the patient is considered a candidate for TPA administration. Basically, it breaks down the clot. Therefore, we remove the obstacle that is now impeding our blood flow to the brain. It does require an accurate body weight in kilograms, simply because it's supposed to be administered within 3 to 4 hours. American Heart Association tells us within about 4 hours. The FDA says within 3 hours. So 3 to 4 hours it needs to be administered. So again, it's important to know when did Mr. Jones start having the signs and symptoms of a stroke. The dosage is 0.9 milligrams per kilogram, so your max dose is basically 90 milligrams. And what you're going to do is that based on the weight, you will give the first 10% as a bolus over 1 minute, and your remaining dose runs for over 1 hour. So again, that separate dedicated IV line on an infusion pump is critical and is required. You are going to do neurostatus with vital signs every 15 minutes. And do note that if your patient does not improve or neurostatus declines, you immediately return back to the CT scanner. The last thing we want to see is a patient with a hemorrhagic stroke, which here's examples of both of them. That you can see the one on the right is severe because there's even a midline shift. We've lost one of the ventricles that are already in there. We can see the bleed that is going on posteriorly here. So obviously this is what you see immediately with a hemorrhagic stroke, and then this patient would not be the candidate to receive TPA. So with neuro and thinking about stroke, also think about the subarachnoid hemorrhage that can occur, and it's due to a hypertensive crisis. And you can get a hemorrhage from a brain tumor, and it all leads to a hemorrhagic stroke. Patients say it's the worst headache they ever have. They feel like there was like this clap that occurred up in their head. They become photophobic, so they're very light sensitive. They could have nausea and vomiting, nuchal rigidity, stiff neck. And then they could have Kernig sign versus Budensky sign. Kernig sign is that when they extend their leg out, they have pain in the hamstring. Budinsky sign is that if you the hips will flex up if you try to bring the neck up. Then you'll see them bring their hips up. So these are classic things that you get with subarachnoid hemorrhage. Thunderclap headache, photophobia, nuchal rigidity, Koenig sign, and Budinsky sign. If you see those, you're going to immediately think subarachnoid hemorrhage. And so how do you determine if your patient is going to the OR? If they're very symptomatic and they've got a blood area of about like 1 to 2 millimeters in there, then the patient is pretty much going to be considered of having to go to the operating room for evacuation of that hemorrhage, or like we do with like subdural hematomas. But the thing is, you can see where this is going to affect the patient's Monroe-Kelly doctrine again. If there's a lot of bleeding, then I'm going to lose brain and cerebral spinal fluid space. Love case scenario. So let's look at this one here. You have a female patient. She's 74 years old. She got admitted early this morning for weakness and fatigue. A fellow nurse calls you and tells you, I am not sure what is going on with my lady in here, but when I got in here, she immediately leaned to me and said, I am very weak and my left side is heavy feeling. The patient has a history of some hypertension, and her family stated that their doctor said she has an irregular heartbeat. So with that in mind, then what are your initial nursing actions in this case? First thing, let's get the patient into a safe position. If she was standing up and she sort of like leaned into the nurse, says, I feel weak, and so forth, let's get her to a chair, get her back to bed. The last thing we want to do is try to take care of this lady laying on the floor. Does she have A, B's, and C's? We're going to assess all that. You want to assess her neurologically. You want to say, how long have you felt like this? Because now you're going to establish that baseline. The other thing too, this would be great to go ahead and say to her, I want to just check in and see if you can, how well you can do a little test with me. And you do that Presbyterian assessment, that stroke screening, that B fast. Of course, you would make her NPO. You would check her pulse ox, so forth, but then based on your B fast assessment, you're getting a CT scan as quickly as possible. You're accessing her IV. You're maybe trying to establish another one. You're also getting the 12-lead ECG. You also want to check her blood glucose. She's been in the hospital now for a day or so. Has she been eating? She's older. She may not tolerate that change in blood sugar very well. And so your plan would be, I'm going to get her to a place, you determine basically she's having a stroke, and you identify that, and your plan is for immediate transfer to the stroke unit or to the stroke lab if she has an ischemic stroke. And that ends this section as well, and we will continue moving on.